We're going to talk about protocols and standards in the carotid. And I am probably the biggest standard protocol person that you will ever meet. It makes it so much easier for the sonographers and the physicians when all the exams are performed the same way, when the annotation is the same way, and it makes it a lot easier because there's a lot less typing. And so we have standard protocols for almost all of our examinations, and I think that's very, very important. So we're going to talk about the protocols. And the first thing you need to do is to optimize your grayscale imaging, because if you don't see it on grayscale, then, because that's always your first line exam. You always compare what you see on grayscale imaging to color and spectral Doppler. So you need to choose the correct transducer. It's a trade-off between penetration and image resolution. And I personally have a transducer that I hate, and it's used in almost every carotid artery examination. And that's because one of my colleagues likes it, and occasionally he wins the battle because you can get a lot better penetration with that 9 megahertz. I personally prefer to use a 12 megahertz for a carotid because I can see grayscale, I can see plaque so much better. But the sonographers end up taking the path of least resistance, which is usually to use the 9. If they look at a patient and say, that's a big patient, I'm just going to use the 9. I'm not going to have to fool with transducer changing. But then you need to optimize your color and spectral Doppler, and you always need to angle correct, always. And that goes without saying, then never use an angle greater than 60 degrees because you're not going to get anything that's meaningful in terms of a peak systolic velocity. So in terms of the imaging protocol for the grayscale, you should do proximal and distal common carotid artery, both in the long and the trans. And when you take those images, the mid common carotid artery will come for free. And then you need to evaluate those with color and spectral Doppler in the longitudinal plane. And by the way, this reminds me, there is a protocol, SRU, AIUM, and ACR have gotten together on carotid artery protocols, and they are on the websites of those respective places and of those respective societies. So you need to look proximal and distal, and then the distal CCA, peak systolic velocity, measure that 2 centimeters from the bifurcation. Why 2 centimeters? Why not 1? Why not 3? Well, it's standardized because there have been a few studies that show that depending on where you measure in the CCA, you're going to get a different peak systolic velocity number, even in the same patient. So we're all trying to standardize what we do so we can compare apples and apples. So you assess the plaque in the carotid bulb by grayscale, and that's in the long and the trans. And then we also take a color and spectral Doppler in the longitudinal plane. And that's a little bit of an odd waveform. I don't usually pay attention to that, but sometimes I do if there's significant stenosis in the bulb and it doesn't extend too much into the ICA. So sometimes that will help you. Most of the time, that piece, the color and spectral Doppler in the bulb, is not all that useful. But then we look at the bifurcation and assess the amount of plaque. Because you're on the grayscale, you're trying to say, okay, how much plaque is there? Am I going to believe what I get in the color and spectral Doppler? How much extra playing around am I going to need to do with the spectral and color Doppler, given the amount of plaque? And does it all make sense? So in the ICA, proximal ICA, CCA in the long and the trans on the grayscale, and then color and spectral Doppler in the longitudinal plane. And in the ICA with color and spectral Doppler, we look at the proximal, mid, and distal peak systolic velocity and end diastolic velocity. And this will be in this is in your handouts, so in that CD. Grayscale, same thing, but we only really look at the proximal ECA, both long and trans in the grayscale, and then color and spectral Doppler in the longitudinal plane. And really, you really only care about peak systolic velocity. Vertebral artery, we really don't look at that in the grayscale. Sometimes it's quite challenging to see, and so we really just look at it in color and spectral Doppler in the longitudinal plane. And then we always take an image of the table. All of these ultrasound devices have tables on them that will calculate the ratios automatically. But you need to be familiar with what your particular ultrasound equipment uses and how it calculates its ICA-CCA ratio. Do you all know that? How it calculates it? I see at least one person that knows that. This is really very important. There's a couple of options, and the manufacturers may have decided for you, but you need to know what the answer is. So option A, use the highest peak systolic velocity in the ICA. And by highest peak systolic velocity in the ICA, they will take it wherever it happens. If it's in the distal, even though it's maybe from an artery that's diving down and there's really not a stenosis, or the mid, or the proximal, it'll take the highest. Option B is proximal ICA peak systolic velocity. So you need to know which one. And I'll show you an example of that in a minute. So this is an example of a beautiful common. I'd like to have a common that looked like that. All of us would. Here is the distal common. So these are typical grayscale images. Here's the ICA. Maybe a tiny little bit of plaque, maybe a tiny bit there. There's a little bit of plaque in the ECA here, but we'll be able to figure out that it's ECA from all the methods and maneuvers that we talked about in the prior lecture. And then we look in the transverse plane, in the proximal CCA, distal CCA, the bulb, bifurcation. And then we start with the color and spectral Doppler. You can do both on the same one. You don't have to do color all the way up and then spectral all the way up. So this is a typical normal study for proximal CCA. Here's the distal CCA, ICA, and the bulb. So you want the takeoff off the ICA. And here is the proximal ICA. Always display the angle correction so you know if that angle that was performed is under 60. Here's the mid. And you can see, this is interesting, I can't see the color box. See here you can see the angle, and to see whether if there is a jet, if it's parallel to that, or if it's posterior to the if it is angled with the posterior wall, if there's no stenosis. But I can't see that on this image, because the box with the calculation goes over it. So my sonographers are so wonderful. They take another one without that table to show me exactly what a good job they did in terms of measuring and the angle. So you need to be able to see the data that they're giving you. And then here's the distal ICA. And again, an evaluation of the actual angle. All these need to be angle corrected. And then this is the ECA and peak systolic velocity measurement in the ECA. And that's a normal standard carotid. And then here's the vert. Now here's the table. This is on a Sequoia. And you can see that the proximal measurement is 0.41 here. And mid is 0.41, and then distal is 0.44. So actually this machine took the 0.44, which is the distal peak systolic velocity. So you have to know what your machine is doing, because you're responsible for it. So that's the normal imaging protocol. Now let's get to the standards. This is pretty interesting. Back in the day, when I was a resident, I already spoke of the fact that we really didn't have to measure a table. We just looked at peak systolic velocity ratios. But we've gotten a little bit more sophisticated than that. And this is, again, to remind you that that peak systolic velocity goes up with diameter stenosis. And we've talked about this table. So what degree of stenosis is important? Well, we found that It has been found that carotid endarterectomy is more beneficial than medical therapy in symptomatic patients with 70 to 99% stenosis. And it's a little bit frustrating because one study will use 70%, another study will use 60%, another study will use 80%, and yet the ultrasound versus angiography studies might have used a different cutoff. So all of these are pretty challenging to figure out exactly what you should use. Well, the asymptomatic carotid atherosclerosis study showed stroke reduction in patients with greater than 60%. So again, what's the difference in peak systolic velocity versus 70 versus 60? And this is also to remind you that there are also different ways of measuring the lumen diameter. It's basically what's the denominator. So here, the NASET study is looking at the distal ICA, whereas in the old days, we used to look at the proximal CCA as some kind of evaluation. And the European carotid surgery trial looked at the overall bulb. So again, when you're reading the literature critically, you have to say, what are their standards? How are they measuring it? And look into it very, very carefully. Well, the Society of Radiologists in Ultrasound had a consensus conference where they had vascular surgeons, they had cardiologists, they had radiologists, and they came up with this table several years ago. And if it's normal, the peak systolic velocity is going to be less than 125. You're not going to see a visible stenosis. The ICA-CCA ratio is going to be less than 2, and end diastolic velocity is going to be less than 40. So we use as a less than 50%, less than 125, basically. Less than 2 for ICA-CCA ratio, and less than 40 for EDV. And then once it gets over 125, up to 230, it's between 50 and 69%. So the SRU conference chose to use 70% and above as what would be significant. And so an ICA-CCA ratio of anywhere between 2 and 4 is what would be in this category. And then you can see if it's greater than 230, we call it 70, greater than 70% to near occlusion, and greater than 4 for ICA-CCA ratio. And then also the end diastolic velocity. Remember on the last talk I told you we would talk about this again. And if you have end diastolic velocity of greater than 100, then also you need to think about a greater than 70% stenosis. So I'm sure in your labs it's going to be like ours, where we really don't do a lot of angiography anymore. In my institution, we have several accredited vascular labs, and the vascular surgeons mostly, I think, just go with ultrasound. And occasionally, if it's disparate results, they'll do a CTA or an MRA. But we don't have a lot of correlative data. So for those labs that don't have a lot of correlative data, I would recommend that you use this table. And near occlusion, it's quite variable. Total occlusion, we've already talked about. So which one to use? If you're a new lab, I would use the SRU criteria, at least until you've had a chance to evaluate all your correlative data. And if you're an existing lab, assess the accuracy. And this is something that the ICAVL did back when we were accrediting with them. And I thought that was very, very good, because if you're doing a great job, go ahead and keep using your standards. There's no reason to change. But if you don't have them, or if it's hard to assess your accuracy, then I would recommend the results of this multidisciplinary panel. We are going to talk for a little bit, because protocols and techniques are quick in the carotid. We're going to talk about the carotid stent ultrasound technique. Back many years now, Dr. Gary Rubin was one of the earliest adopters of the carotid stent placement, and came to us and said, look, do you want to figure out what if ultrasound is any good in looking at carotid stents? And I said, you bet, we'd love to do that. And so what we came up with was that it should just be a standard carotid evaluation, but we've added a few things. So basically standard plus a few things. You need to look at the CCA, you need to look at the ICA, the ECA, and the vertebral artery, just like usual. But then you also should look proximal to the stent, which is typically now in the common carotid artery, because we're going to be looking for ratios and peak systolic velocities within the stent and at places where that stent changes diameter. So in the stent, we look proximal, mid, and distal. And then distal to the stent, because that is an occasional spot where the stent can collapse. And so we look at all of these places. Additionally, we also look at the ECA, because the stent crosses the ECA. And so at each of those locations in the stent, you look for peak systolic velocity and end diastolic velocity and look for a ratio. And angle less than 60%. And again, we haven't really talked about it too much, but in terms of vascular lab accreditation, that's very, very important, because that establishes your standards, that you are the same and have the same great standards as ICAVL or American College of Radiology. And it's very, very important. And so now, that was way back in 97. So now, many other studies have been performed, and it's still kind of hard to determine what is the exact good cutoff to call a stent restenotic. And I think there's a confluence now of agreement around 70%, that 70%, once you get above 70%, you should consider treating. And so for that ultrasound criteria, because back in 95, 96, when we were doing the study, we really only had a couple of stents that stenosed. But there's been enough data accumulating now that it seems like most people are thinking peak systolic velocity in or distal to the stent of greater than 3. And that can be any location in the stent. So this is an image of a normal carotid stent. They're really pretty cool. You can get really pretty ultrasounds with them. And this is in the distal common, but pre-stent. So the sonographers are going to be very important in terms of telling you where they are. This is, and you can imagine that you've got a big diameter here, but now we're going into the ICA, so the peak systolic velocity, because it's just plumbing, is going to increase, but it's not likely significant. So this is the proximal ICA, or in the bulb actually here. It's still in the proximal stent. And then we're seeing in the transverse plane a grayscale image of the stent, and it looks great. And then we're looking in the ICA at the stent, grayscale, and which is the mid stent, because the stent goes from the common to the ICA. And we're not getting any change, any significant gradation here. Then in the distal stent, but mid ICA. And then in the distal internal post stent, because that is another place, again, where you could have a stent collapse. So we've looked at all those places, and then also at the ECA to see if that is patent or if there is a stenosis there. And that's the normal protocol for a stent. They're pretty cool. You can usually get some pretty nice pictures. And so, for example, in this patient, there's an ICA-CCA ratio of 0.6, so there's no stenosis here, completely normal. This is a patient with a nearly occluded carotid stent, and we're in the proximal CCA. We're not at the stent yet. Is this normal or abnormal? Abnormal, high resistance flow pattern, externalization of the common. There's probably something not good with this stent. And you can see in the proximal ICA that it is nearly occluded. There's maybe a little trickle of flow through here. And we are looking in the longitudinal plane, showing that we can see jugular. We're in low flow settings, but we're not seeing any flow in the stent, which is right here. And actually looking at the ECA with the temporal tap. So we know that, we knew the stent was in the ICA anyway, but we know that we have correct settings to look for flow, so we're very, very concerned about this stent. And maybe it's open because in the mid-stent and distally, we're seeing a little bit of a blip. If it's open, it's not open for too long. So that is probably the most extreme example of something that is nearly occluded, but perhaps not completely occluded. I just want to show you an image of some vulnerable plaque. Dr. Pollock showed some nice images of it before. This was from this week, where really there might be a little bit of ulceration. In those patients that have both hard and soft plaque that's very irregular like this, I always suggest that these patients that are at higher risk for TIA and stroke, and hope that the physician evaluates them, at least for aspirin. And this is interesting because proximal, there's really not a peak systolic velocity elevation, and distal, there's not a peak systolic velocity elevation. So there's a nasty looking plaque there, but it's not hemodynamically significant, but it still could be causing TIA and stroke. And see the ICA-CCA ratio is 1.6. So it doesn't always have to be stenotic to cause problems. One last thing from the literature, we have not done at UAB carotid artery ultrasound contrast exams for a long, long time, but I'm hopeful that this will happen. There are some reports now of looking at the vascularity of plaques, and this is the money slide. These are superimposition of the grayscale and the color, or of the grayscale with contrast, and you can see that the lumen doesn't go all the way up to the wall because there is a little bit of plaque there, and post-contrast there are little blips of contrast, and so this plaque is being perfused, and we're able to see it with ultrasound contrast, and hopefully at some point this may add in our evaluation of which plaques need to be perhaps intervened on or at least evaluated further and the patient watched more closely. Thank you.